crank up? All right. I'm going to have to sit for this, I'm afraid. I'm dealing with a little bit of a spine problem. I'm a little more comfortable in this position. Anyway, I'm Dr. Claudio Feller. It's always a little daunting to follow Dr. Collar because she does such a nice job with her presentation, but we'll see if I can manage to not show myself down too far. My primary topics to talk about deep brain stimulation are really, in essence, the surgical management of movement disorders, which is, it's not a new phenomenon. Surgical treatment of movement disorders is actually quite old. It goes back over 100 years. And I kind of like to tell a little bit about the history because, you know, I'll show you some results slides and you wonder what that really means. And in medicine, we're always a little skeptical when we read articles about results because if we didn't see the result, we don't necessarily know what it really was. And so it's kind of interesting to talk about the surgical management of movement disorders, which I'll just give you just a moment on it. The history is quite interesting. Of course, Parkinson's disease was described in the 1800s, and it took 100 years from description to the first brave neurosurgeon deciding he was going to try to do something for the tremor. And Dr. Collar points out that tremor is not the primary symptom that we use to diagnose Parkinsonism, but it is a very visible symptom, right? Anybody that's seen a patient with tremor, you know it's obvious there's a tremor. And so the original treatment was directed at the tremor. And what do you suppose some very smart neurosurgeon in roughly 1910 did? He went and did a brain operation and resected the motor strip, the part of the brain that causes you to initiate motion. And guess what? 100% of patients, relief of tremor. Of course, they were paralyzed. And so I'm gonna say that to you guys because that's not where we are today. We're in a far better place today. And I'm going to show you some images of patients, some videos actually, of patients that are either literally in the process of having a brain operation for a movement disorder, or in patients, also a case where there's a pre-procedural and post-operative video of how the patient moves. So that I want you to take away from this a very important thing. And that is movement disorders generally tend to be progressive phenomenon. In other words, most people when they're young, they don't have them, and at some point they develop symptoms, and those symptoms become worse with time because, particularly in Parkinsonism, it's because you're losing the cells in your brain that produce the dopamine that's necessary for you to have normal motion. Fair enough? So things get worse. You know, it's like the 100-year-old guy that gets interviewed on radio, and you know, the interviewer, who's probably 25 years old and wet behind the ears, says, "Well, sir, it's so wonderful that you've made it to be 100 years old." And his response is, "What do you mean it's wonderful? You know, my friends are all gone, and if you think I'm living in a 25-year-old body, you'd be wrong." So as we get older, things break. My back's a problem today. You know, things are not what they were. And these are progressive disorders, and that's important to note because we generally don't provide perfection in an operation. I cannot take any one of you and make you half your age, and you follow what I'm saying? That's not the way it works. So these are talks, these three talks really are not about definitive cure. They are about movement disorder management. And that, for example, is why we have a neurologist, a neurosurgeon, and a physical therapist talking to you, because it takes these things and more. It takes speech therapy, it takes occupational therapy, it sometimes takes behavioral medicine to get someone optimally managed. Fair enough? So, you know, if you seek treatment with us, we don't do something and then say, see you later, have a nice life. You know, this is kind of a relationship that you have to develop with us, that we develop with you, and it goes somewhere for a long time. So having said all that, did that entertain everybody? Good. Okay, so Dr. Collar's already mentioned there's a lot of different sorts of movement disorders. I'm not going to go through this list except to point out that movement disorders are actually pretty common. I think this is kind of vacillating in and out, but if you're over 80, your chance of having some movement disorder is significant, at least an essential or what's sometimes called familial tremor. The thing about movement disorders, as many of you know, is it takes you out of society. You know, particularly if you have a tremor disorder or if you have bradykinesia or slow motion, because everyone watches you as you walk into a restaurant to have lunch, and you know, they see you shaking as you try to eat your food, and they take bets on whether you're going to spill it on your lap or get it into your mouth. I mean, that's not a comfortable situation for anyone to be in. No one wants to be the subject of that attention. So I think of movement disorders as kind of imprisoning from a societal point of view. And our main goal, meaning those of us that treat movement disorders, is to find a way to get a patient back out of their house and able to participate in things that we all want to do, which is visit people, drink a glass of water or tea. I prefer tea to water myself, but you know, you may not like tea, but I do. Anyway, so there, again, some of these are overlapping with Dr. Collar's presentation. There are features of Parkinsonism that are sentinel features. And we can treat sometimes all of these and sometimes some of these, depending on what the specific problem that a patient is most concerned about might be. Particularly from a brain operation point of view, it's important to know what symptom you're treating, because some of the actual locations in which we might put an electrode produce a more powerful effect in, let's say, tremor, or this other one might be better for rigidity and the bradykinesia, but maybe not as good for the tremor. That's just life. That's how the big boy or the big girl upstairs made our brains. So to some extent, we have to sit with a patient, and we actually sit in our evaluation team meetings, and we discuss what might be the best or the optimal target given on that patient. Fair enough? You know, is it essential tremor? Is it Parkinson's disease? This is really just a reminder slide for me to mention that we can treat both. Again, essential tremor has a number of pseudonyms, like familial tremor, for example. But there are many reasons why people have tremors, and most of them we can have some positive impact on. We do a team evaluation. I think that's critical. I started doing deep brain stimulation in 1985. That's been a long time ago. At that time, we were doing them for pain, and there was no kind of a comprehensive effort to evaluate any patient. The patient would go to a neurosurgeon that knew how to do the operation. The neurosurgeon would decide, yeah, that patient's well enough, meaning physically able to stand an operation, and doesn't seem to have any contraindications, and we're going to operate on him next week or her next week. And you know, that's kind of the traditional way of practicing medicine, right? Except for these movement disorders, things are multidisciplinary phenomena. I can't make any of you as well as we can make you well. Does that make sense? So it's really important that everyone understand that you have to buy into a plan of treatment. there's no one and you're done kind of a thing. It just doesn't work that way. Now, we hope it's one operation and you're done, but what I'm trying to get at is there are other processes that are important. So this is our team. We use Dr. Collar from neurology does most of our evaluations, and we work with either psychiatry or psychology. It depends. It depends on the things that Dr. Collar alluded to earlier. You know, when I sit and see the patient, because either it's going to be me seeing the patient first or Dr. Collar sees the patient first. You know, if one of us is concerned about overwhelming depression, or, you know, I've been asked to see a few patients with Parkinsonism that had bipolar disorder, you probably need to have a psychiatrist involved in that because they're the ones that are going to manage those extreme disorders. It's not going to be me. That's not my expertise. And then the therapies, and finally myself from neurosurgery. What would we want to do an operation for? Well, you got to have disabling features of the disease. You know, I'm not going to operate on somebody that comes in and this is their tremor, because that's not impeding anyone from doing anything. Do you follow what I'm saying? But if you've got a gross Parkinson's tremor, that's a different thing altogether, and it impedes that with all the other features, impedes your ability to get along and do things. So the other thing is failure of medical management. In all fairness, we do offer deep brain stimulation earlier in the course now than we used to for movement disorders, because it's been shown that patients get a longer good result if you engage the operation earlier in the course. But you still get some medical management first. For one reason, because the results of the medical management is actually highly predictive of the outcome or the result of the surgery. So patients that at least have a response to dopamines, as Dr. Collar spoke earlier, are much more likely to get a good result with an operation than if they have no response. So again, that doesn't mean that we don't sometimes do a procedure on a patient that didn't get a response, but it's important to recognize that and to have that open conversation with a patient, right? You want to know what your real possibilities are. And if you ever come to my office, you'll find out I don't blow a lot of smoke. In fact, a lot of people tell me they'd like a little smoke. I never learned how to do smoke. Smoke generation's not in my forte. I don't know. But so we like to have honest, direct conversation. It's the only way to do it. A patient has to have a reasonable expectation of their outcome. You know, if you're expecting to be 20 but you're 76, forget it. We're not going to make any forward progress. We're going to make backward progress. So reasonable expectations. You can't have lost too much of your cognition. In other words, you still have to know who you are, where you are. You need to be able to add and subtract. I mean, the reason is that when we do these operations, sometimes they do make that worse. Not who you are, what you are, when you are, but your ability to do math, for example, really higher cognitive function can be diminished. And, you know, we don't want to hurt anybody. We don't want to turn someone that's kind of making do okay and turn them into making bad, you know, just not able to manage. So, and medical contraindications, obviously if you're on a blood thinner and you can't come off the blood thinner, guess what? I'm not going to put a probe in anyone's brain on a blood thinner, because that translates into bleeding in the brain, and if you don't know, that's bad. Okay, there are things that are good, there are things that are bad, that qualifies as bad. You get that, right? That's bad, yeah. Okay. And since you guys have had lunch, I'm going to keep this a little light because I don't want anybody starting to snooze. All right. We've got a number of things that we're approved for with DBS now. Parkinson's disease, essential tremor, dystonia, and I'm actually going to show you a dystonia case in a little bit. They're not that common, but I love showing this set of videos because it shows you how clearly someone is better and yet how clearly they're not well. And yet I can tell you that patient, you know, thinks that the moon was hung because he had that operation. And obsessive compulsive disorder is the latest. There are other surgical procedures that can be done for some of these things. It's not just necessarily deep brain stimulation. But today I'm going to be talking about deep brain stimulation for these movement disorders, in large part because they're fundamentally the safest way to approach these disorders in the contemporary world. There are other things that we're looking at. There are scientific trials going on right now using deep brain stimulation to abort epilepsy, to treat depression, dementia, although I don't think the dementia trial's going very well. I actually have a friend that sent his mother into that, and it didn't go very well. The one that I'm most interested in happens to be obesity. I mean, obesity is our leading disease in this country today. It's a serious problem, and it obviously produces a whole lot of secondary phenomenon, like, for example, diabetes and hypertension and so on. So, bariatric surgery, you guys have heard about that, works very well initially, and then there seems to be some failure rates after about 2 years. And I believe that the future will be in the brain. We'll see. So, surgery, advantages. Well, we can control things. We usually can reduce medication by half. Sometimes people get totally off of it, but not usually. If you can reduce it by half, that's pretty good, because if you think about it, if you're taking dopaminergic medications, patients get into what Dr. Collar pointed out, the Michael J. syndrome of too much motion. It's really not his syndrome, but you guys have all seen that he becomes what's called dyskinetic, which is these really kind of erratic, almost forceful movements of the arms and legs. And that happens because when you take a medicine, your dose goes up in your bloodstream, but then it starts tapering off. And if you're giving a pill that needs to last 6 hours, obviously an hour into it, there's going to be a lot more in your bloodstream than there is at 3 hours. So initially you got too much motion, then you taper off and you got about the right amount of motion, then you taper off and you are oftentimes in what's called off. Everybody know what off is? Off means basically cemented. You can't move. And then you take your next dose and you go through all that again. And I do think things are better now with some of the newer compounds, but the phenomenon still exists. And what's the disadvantage? Well, you got to have an operation. Hey, I live in the operating room, pretty much 3 or 4 days a week. And so for me, that's kind of like where I live. And for you guys, it's where you don't want to be. And I totally understand that. But it's not the biggest evil in the world. If you want to get better, sometimes it's what you got to do. But keep in mind, it's not the panacea. It's not going to make you 25. It's not going to make you, let's see. It's not going to make you walk up to a bull and smack him in the head and outrun him. That's a good Wyoming thing to say, right? That works, right? Everybody understands that one. Yeah. Yeah, no, it's not going to do that. There are advantages. It's relatively safe, the subcortical stimulation. There is a risk of death. I'll tell you right on the front end, it's about 1%. Since 1985, I have not killed anybody. And I'll just knock on wood on that one. I can tell you why the risk of death is thought to be 1%. It actually has to do, I believe, with the original electrode that was used, which was, I don't have a picture of it, but it was a device that had a little hook on the end of it that allowed you to put an instrument on that hook and drive it down to where it needed to go. Made sense, right? Except that that little hook would scar in around the brain, and then if the electrode broke, you had to pull it out, you'd stir up bleeding, and guess what? What did I say earlier? Bleeding in the brain is bad. I'm a neurosurgeon. I'm very simple-minded about that. Bleeding in the brain is bad. And I think that with the contemporary electrodes, actually, it's exceedingly rare to have a mortality or a death from these operations. But nonetheless, historically, I think it's correct to show that there's a 1% risk. We don't destroy anything putting these in. There are disadvantages. This is in contrast to simply putting a probe in and burning a little part of the brain, what's called, for example, a thalamotomy, something that I've done a lot of. This costs a little bit more per year because there's a battery that has to be maintained. But on the other hand, it's less likely that you'll produce these kind of cognitive phenomenon. It's less likely that you'll produce any permanent numbness. In other words, the side effects are a lot less with stimulation, if you will, than with what we call a destructive lesion. So we weigh all these things in a given patient, but frankly, it's been 6 years since I've done a thalamotomy, so we're increasingly just doing stimulation. Again, we want to reduce symptoms. We want to make everyone more engaged with their world, improving activities of daily living, and improve everyone's quality of life. That's what it's all about, right? It's not about sitting at home watching TV. Although sitting at home watching TV is nice in the evenings. I get my dog sitting next to me, The world is good. All right, let's get into the surgery. I'm going to stand up for a minute. I got tired of sitting. So to do these operations, we're going into the center of the brain. And you understand that that's yay far down from the surface. And we're operating on a target that's usually about 1/8 of an inch in size. So if you think about the precision with which you have to be there, we've got to have a way of getting there precisely. I think I'm pretty good at what I do, but I promise you that I can't point at your subthalamic nucleus or even the posterior aspect of the thalamus just looking at you. It's not right there. I don't know exactly where it is. And so we have to use some sort of guidance system. And to do that, we like to place a frame on the head. And I'm going to show you what all this looks like, okay? So just don't get mystified by the words. I just want to lay the process out. We place a frame on the head, and that's probably the worst part of the day for a patient because I have to numb up 4 spots on the head, one above each eyebrow, one on the back of each side of the head, and then we have to secure a frame to the skull. And that's done with some sharp pins. And it's numb. Once we get you numbed up, all you feel is a little bit of pressure. But, I'm kind of a needle-phobic person. I don't like having shots, and maybe most of you don't either. And I get where that's really unpleasant, and that makes sense, right? Nobody wants to have a shot. How many of you like going to the dentist? Well, if anybody raises their hand, I'm going to write a psychiatric consult for you. Nobody likes going to the dentist. I hate going to the dentist, and yet they do good stuff for me. So anyway, so then we have some targets in the brain that we have to image, and I'll show you we can do it different ways. And through those targets, we have a whole series of different brain atlases that we can derive our actual surgical target from. So this is in essence a derivation. In other words, we use a couple places that are in known space in the brain, and we derive where we're going. And you'll see that the imaging puts you on a grid, and actually the contemporary way of doing it is we have a very thin section MRI, so 1 millimeter cuts. So there's a great precision in that data set that we obtain. We have that on an operating computer, and then the day of surgery, we put the frame on a patient, we go get a CAT scan, again with millimeter thick cuts, and that allows us to merge those 2 data sets, and now the MRI of your brain, which is the best way to look at the brain, but not necessarily the skull, is now in the same space as the frame, and you go from one to the other. I'll show you that. It's pretty neat. Then we have to do an exploration. Dr. Collar mentioned that ultrasound's being used to treat tremor. And there are other ways that are being used to treat tremor without making an incision as well. The problem with those methods generally is that you don't have a way of refining what you're focusing your intent on, whether it's ultrasound or radiation treatment, you can't focus it because you don't know for certain that you're looking at this millimeter or that millimeter. In other words, each of us has a brain that's a little bit different. You know, the big boy upstairs did not make us all the same. And particularly in the tremor target, there's a lot of variance. So I've been very reticent to go that route because, frankly, my first task is to hurt no one. You know, I'd rather not hurt anybody than, you know, and not take risk with that than take risk and hope to make them better. I'm kind of funny about that. Does that make sense? I don't want to hurt you. And so I think that there's pros and cons to all these methods. But anyway, so we want to explore it. I'm going to show you that as well. And then, you know, we make a decision about what we're doing, and then we deal with the outcomes. So this is how we used to do it when I first started my training. This would have been early 80s method. And we used to do, you can actually see that there's a grid on this patient because you see these X-ray plates are actually attached to a frame. And we would then put dye into the ventricles, the fluid spaces of the brain. And the dye allows us to see what's called the anterior and posterior commissures, which are those two places that I was indicating that we derive our targets from. And then we'd sit down with an atlas, and it was really entertaining to do that in an operating room. We'd actually have a huge atlas in there, and I'll never forget Dr. Sam Hunter, who I was doing those surgeries with. We would sit there and noodle around and use a protractor and measure and whatnot. It was, I mean, yeah, we were mathematicians. The problem with that is, what do you think? Well, there's problems with the dye. Very commonly produces intractable seizures for 24 hours. So, you know, there were some patients, we'd finish our operation, lighten up the sedation, they'd start having seizures, we'd put them back under sedation, you know, put a breathing tube in, move them to the ICU, and that was 24 hours. Well, you know, that's not nice. That's really not nice at all, right? So when I did my fellowship, I worked with really one of the grand masters, and he was the first guy that ever started doing these with CAT scan guidance. And so we would actually just use this side as the CAT scan. And we could see the targets, and he was able to prove that his precision was just as good as using the ventriculography. So the world moved away from ventriculography and moved into CAT scan. When you think about it, MRI came into common use in the late 80s, and that doesn't mean it was current generation MRI. Remember that these things all have had generational improvements. But at any rate, back in the mid-90s, I think, is when we started routinely using MRI to guide these operations. And so here you see, we've got a patient that we've got two data sets, an MRI and a CAT scan, and you can actually window back and forth to verify what you're looking at from one data set to the next. We don't even really have to do that anymore with the new computer systems. But that's called image fusion. And the way it works usually is I'll have an MRI on the operating or the planning computer, and I'll sit down the night before with that computer, and I'll actually plan my whole operation. Because we know we want to go through here and not there, and we want to miss that, but get over. Does that make sense? So you plan your entire path. If you were driving, you know, from here to, I don't know, where do you guys want to drive to? Denver's too easy. You want to drive from here to Glenwood Springs, Colorado. You got a number of different ways to go. You know, you might choose the fast route, which is down to Denver on I-25, hit I-76, pop on I-70, and head west. I hate that way. I hate that way. Too many cars. So I personally prefer, you know, going over to Laramie, heading south, Walden, what's the next town? Starts with a K. Kremling to Walcott, In the summer, I like taking the Forest Service road because it's really pretty and a lot shorter, but you don't go as fast. And then hop on I-70 and hit that last little section. The point is, I plan the operation just like I plan my drive. Fair enough? And then the next day we can do the image fusion with the CAT scan and go to town. Well, this is our tremor target right there in the back part of the thalamus. It's called ventralis intermedialis, or VIM for short. And that's 1/8 of an inch front to back. And if you're off the center of that, if you're off by 1 millimeter, you can still get a decent result. You know, you might think if you're off by 1 millimeter, it's kind of like you're trying to have a steak in Cheyenne, but you're actually in Laramie. You're probably still going to get a good steak in Laramie. If you're off by 2 millimeters, you're in Los Angeles. Okay, you're having to deal with those nutty people, and they don't have steak out there because, you know, they're all vegans or I don't know what. I don't know. Anyway, so you understand what I'm saying. Precision really translates directly to outcome. When we go to the subthalamic nucleus, we go through a number of areas of the brain to get there. And this goes back to the intraoperative data collection, which, you know, it's one thing to plan the whole thing. It's another thing to have this fancy frame. It's a third thing altogether to verify and validate that we are where we want to be. Okay, because we don't use intraoperative imaging with, you know, I'm not getting an intraoperative MRI to prove that the electrode's correct. We use physiology. So how do we do that? Well, all these areas of the brain have different signatures. You know, just like I sign my name my way, and you sign your name your way, and you sign yours your way. You know, we have different names. And you go through different places, and you'll see, for example, that there's substantially different rates of firing between the thalamus, where we start recording, and the subthalamic nucleus. And then if we drop into just about 2 millimeters beyond there into the substantia nigra, it has a very high rate of firing. And we're listening to that. Yeah, we look at it on an oscilloscope, but the purpose of the oscilloscope simply tells you the size of the cells you're seeing, so it tells you proximity. But it's actually the ear that you train with years of doing this to know what you're listening to. And that's me as a far younger person, probably about 25 or 30 pounds less weight, but who's looking at that? And I've got a patient here, and I'm testing the patient's rigidity while I stimulate their brain. The patient's awake. All right. You see that frame is what we actually apply to the head. It's not that entire thing. It's actually a base ring, but then when we're in the operating room, we have to stick the rest of the stuff on top. But the point is that you see that the head's actually restrained. Patient's under very light sedation. We're speaking to the patient. I need the patient to move. You'll actually see a live operation in a moment. We ask them to do things while we stimulate. It's the only way to properly validate our targets. And this is kind of a newer picture of a deep brain stimulator, and this is newer generation of the same frame. This is black. Yeah. It actually is a very cool frame because the pieces fit together and slide better. Technology and advancement, that's what it's all about. Anyway, but you see we've got me there, and I've got surgical assistants on the far right, and there's the anesthesiologist on the far side, you know, making the patient stays calm because, you know, I can't use a whole lot of sedation. I need the patient to be, you know, able to help me and not be anxious. So it helps to have an anesthesiologist that'll talk to somebody, you know, nicely and soothingly, right? This is my back, and that's a recording device. It's actually the oscilloscope tracing. And you can see, actually, it looks like there's a lot of cells in there. That's actually background noise. But you can see a few cells. Well, you're probably not close enough to see it, but If you were here, you'd see there's a few cells that are spiking beyond the noise limiter that I put in there. Okay, let's see if this is going to work. Phil, which button do you think I have to hit to make this video play? Let's try this one. Ay, ay, ay. This is as we go into the operating room, and I said to the patient, hold your arms still. That's pretty flagrant movement disorder. This woman, you don't need to see that again because it kind of scares you, doesn't it? Woman's a generational rancher. All she wants to do, it's just she and her husband. I always like to ask patients, what are you wanting to do that you can't do today? You know, how are you going to validate that I made you better? Her answer, I'd like to be able to fix my husband his lunch. This is during surgery. We're now stimulating. Forgive the fact I got to walk over. And you'll see that I'm having her do some things. And that's better, huh? Would you agree that's better? Not perfect, not perfect. Better? Yeah. And finally, this is at the very end. And I said, tap your fingers. Notice there's still a subtle tremor. But you know that she wasn't able to do that well before we started working. So one of the reasons that we get excited about doing movement disorder surgery is I can see my results right away. The patient can see their result. You know, it's kind of exciting stuff, right? This is 2 weeks later. And you'll notice there's still some residual tremor. I did a one-sided operation, and it was on the left side of the brain, so it would more affect the right hand than the left hand. There are reasons why we did this way. And you'll see that tremor is much better. This is hold your hand still. There's still some escape, but it's not that horrific tremor that was there when we went into surgery, right? The day after surgery, this lady's husband was a bear of a man. I mean, just a huge guy. You know, and I'm kind of a shy, kind of introvert. And Becky Grant, that was time for you to laugh. I'm a shy introvert. And I went to the room to check on her, and this guy was huge. I mean, he was the real deal, big rancher guy. And I walk in the door, and he bounces out of his chair, and he comes running over there and engulfs me in what can only be described as a bear hug. I mean, I almost fell out on the floor. Anyway, so we went out after that 2-week visit, and we went out for lunch. And what do you think she chooses to eat? A rice bowl. Yeah, she spilled a few grains. She did. Not many. Okay, so that kind of gives you an idea of what happens during surgery. I'm going to show you a couple more videos in a moment, because here I'm showing you, graph data. And that's what I said when I started. What's data? Data is kind of like this artificial thing. So pre-op, this is patients with essential tremor. The patients are ranked in the red bars. And this is a disability scale. It's if you can move one segment from the left to the right, you've had a significant improvement in your functional capability, okay? Green is post-op. This is after deep brain stimulation. Now notice this. We started off, everybody's on the right-hand 3. Post-op, one patient is still over here. So one patient didn't get better. Now these are not huge numbers, but there's 13, 12, 20, I think there's about 21 patients. One patient didn't get better. I don't know whether this patient started in this group or started over here. But what you do see is that most of the patients are way over here. So you look at that and you say, wow, we're doing something good. Fair enough? And similarly in Parkinson's tremor, same sort of data. Still, one patient Didn't get any better. Okay. I think you got to take away from that we don't help everybody. We're not able to help everybody. But I kind of am a glass half full person. Look at the majority of the patients. Okay, what does this translate to? Because at the end of the day, hey, only 2 patients are over here completely normal, right? So only 2 patients are normal. But I'm telling you that everybody that moved left one section was substantially better. What does that mean? This is a patient with dystonia. This is a patient with dystonia. Can you imagine this poor guy trying to go out into the world? Can you imagine how miserable he must be with his back? I can only imagine that right about now. We all agree that this is a serious movement disorder, right? I mean, it's evident. There's nothing questionable about that. Okay. He can barely stand up. Okay? This, same guy, after deep brain stimulation. I want you to watch him. Is he standing normally? No. Is he walking normally? No. Anybody debate that he's better? There's no debate, right? I love videos. I mean, that's the reality of what I've been trying to express to you guys, which is we can make most people substantially better. Sometimes people are effectively well, although consider that these are progressive disorders, and over time, you know, the disease will eventually catch up. That's just the sad truth. Now, you know what? We may develop a new drug tomorrow that, you know, becomes the cure. That's a pretty cool set of videos, isn't it? Okay. So I'm going to just spend a few more slides kind of showing you what we're doing of late that I think is really positively impactful. Because remember, I've said a couple times already, devices are changing. And generally, device change is good. Change is good in this kind of a world, in a world where we use stuff to treat a patient. You know, just like, well, I guess last week I would have said, isn't it cool that we have these self-driving cars, but then, you know, then a Tesla, you know, the guy didn't take over the wheel when the car told him to, and the guy kills himself, you know, on self-drive mode, hitting a barrier. I mean, so it doesn't work this week for me to say it about a Tesla, but generally speaking, you guys agree that the technological advances tend to improve life, sometimes at cost. Like, for example, in ranching, I am not a fan of these Japanese horses. I got a problem with them. They're used a lot in Wyoming. I don't get that. Why would you want to ride on a Yamaha when you can, when you can ride I don't know, but a good horse? They're much more reliable, trust me. Yeah, you fall off of them more often, but they're much more reliable. Anyway, okay, you can have a hemorrhage. If you have a bleeding spell, it's not always a disaster, even though I said, implied anyway earlier, that it's a disaster. But you can have a mortality. I don't think it's very common any longer. You know, at the end of the day, the real issue anymore is side effects. And the reason there's side effects is we put these electrodes into the brain, and the brain's got a lot of structures, right? And a lot of these nuclei that abut each other have different functions. So for example, if I put an electrode into a place to treat tremor, well, it's right next to the sensory nucleus. So when I turn it on, it's conceivable that you might feel some tingling. And you would say, well, I don't want the tingling, even though your tremor's gone. And you would say, I don't want the tingling. And I would say, that's a side effect. Do you follow what I'm saying? So in other words, side effects should not be translated to mean disaster. It simply means because disaster is really more properly it should be interpreted as complication. Okay. As of, I don't know, a year and a half ago or so, in the United States, they released a new electrode that we can use that allows us to mitigate these side effects quite a lot. So instead of having electrodes, as we have for many years now, where there's 4 contacts on the end of a catheter, and they're circumferential, so they generate current around the entire electrode. You know, we have a new electrode that takes the middle 2 contacts and divide them into 3s. So you can now say, I need to move my current this way. So you turn off the backside. And they're called directional leads, and they're fascinating. And actually, the theory translates properly to clinical outcome. And so one of the things that we can do with them is we can actually generate more current into the part of the brain that we need and not generate current into parts of the brain we don't want current. So it improves our ability to create a volume effect within the structure that we're trying to treat, which we couldn't do before because we'd be limited by the side effect of the surrounding electrode or electron dispersal. And this is simply another pair of slides with graphs that simply show that that works out to be true, that you can get better outcomes with this sort of electrode. And I'm very excited about that. You know, we've already done our first implant here, and it's been really quite impressive to program that patient and to see that there's real benefit, not just somebody thought of a good idea and maybe it works, maybe it doesn't. It definitely is a huge deal. The other thing that we've started doing recently is using a device that allows us to get rid of a lot of the cabling when you come to the office. You know, when we have to reprogram a patient, you know, it used to be you'd have to have a programmer attached by cable to an antenna that you'd have to, you know, hold on the skin over the generator, and then the thing was always moving and you were losing contact. And I mean, from a patient point of view, put yourself in the patient's seat for a second. How does a patient feel about the fact you can't even keep your antenna on top of their generator? You know, it kind of erodes confidence a little bit, you think? Don't you think? You know, it'd be kind of like if a real estate agent were to, you know, come up to me and wants me to buy a house, and he doesn't even have the ability to carry like a purchase contract with him, you know? I mean, you gotta question whether that real estate agent really is on the ball. This gentleman's with #1 properties. Anyway, for those of you in the back that didn't figure that out. Anyway, so these things now, you know, you go home, you got your own little controller it's an iPhone. It's really not precisely an iPhone, but it's one of those iDevices. And it Bluetooths to your receiver, and you can have control over your own device within certain limits. And when you come to the office, we can sit there and chat with you and adjust your device via an iPad, and you don't even know that we're necessarily doing anything. We're just playing around with our iPad. Probably, you know, we're reading the news or something, and you think we're distracted, but we're really working. You know what? From a patient satisfaction point of view, these are huge things. The electrode, from a functionality point of view, huge. These sorts of things, from a patient satisfaction, are huge. Pretty excited about all that. Anyway, I took you guys down a long kind of a meandering road, which was kind of fun. Nobody fell asleep. I appreciate that. I could stand up here for hours and talk about this because obviously it's been a bit of a passion of mine for a long time. But I gave you guys a lot to think about. Are there questions left unanswered? Sir? Ma'am. Ma'am before sir. Ladies first.
Do you lose your memory when you have this operation?
The question is, do you lose your memory when you have the operation? what I was trying to say earlier is you can have some downturns. But I would say that what you're asking is, the answer is probably not really. Why did it suddenly get louder?
Hi. We still have a few more minutes before we'll get started with Dr. Feller's presentation, but I did have some information about a support group locally if you're interested, and I'll provide a couple of sheets up here. There won't be enough available for you to take this with you, but you could come and look at the information and write it down. So there is a local Parkinson's disease support group. The meetings are open to the public, and they're held on the first Wednesday of each month at the Laramie County Library. And so the next meeting is this coming Wednesday, April 4th. The meetings are held in the Willow Room from 1:30 to 3 p.m. in the afternoon. And again, on these sheets of paper, the support group leader is Sandra, and her phone number, if you have a pen, and again, I'll put this up here, is 307-274-0057. So again, it's open to the public. You'd be welcome if you needed some more information. And just as an FYI, April is Parkinson's Awareness Month. So you may see some more information on TV or around the community about Parkinson's disease because it is Parkinson's Awareness Month. So again, thank you.